Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. We are at our 161st episode of the Codecast, and today is the last Tuesday in November, which means this is Top 10 Tuesday. I wanted to focus my Codecast on the top 10 telehealth issues that I'm seeing with the new CMS audit since they started, I should say the old ones, but they started their audits back up again, as I mentioned, August 3rd. And I wanted to tell you what is being reviewed, what's being red flagged, so that you can be on the lookout if you are asked for records. And between UPIC audits and pre- and post-payment reviews, you name it, they're out there. And these are the top 10 issues that I see and I want to make sure that you're clear with. Also, later on in the broadcast, I'm going to address the PPE code, the 99072, for when you're supposed to be allowed to bill for some of the expenses relating to some of the public health emergency protocols. And so I'll talk to you about that in a little bit. So let's take a look at what Medicare and some of the third-party payers are looking at. And just to be clear, this is not just for Medicare audits. There are other payers out there that have not only rolled back some of their provisions under the telehealth, even though the public health emergency was extended, but they're making sure that the money that they sent out so quickly when everyone was just thrown into the mix, that they weren't paying for claims that were inappropriate. And what we're finding as right now, which is really sad, is about a 60 to 70% error rate on telehealth services. So first thing first, the audio versus audio and video. So you're probably sick of hearing me talk about this, but many E&M services, and when I say that, I mean any kind of office or outpatient service or new or established patient, hospital, initial hospital, anything like that, really any E&M service, a lot of them have been billed when there was only an audio connection and not an audio and video, as what is under the CARES Act and under the waiver 1135. And many of the private payers also agree with that. Now, you may have that, one contract or those two contracts that do allow for an office visit with a phone call, but you better have it in writing because it is not Medicare and it's not a lot of the payers. So this is something that is not only being audited, but it's being verified by the patient as well, that they didn't have video capabilities. So just know that's coming. Too many other services that were billed under telehealth when there was only a phone or audio visit. And a lot of services are not allowed. So you need to refer to the list that was published by Medicare on what is allowed under audio. And if you took one of my many telehealth webinars, we include that list for you. And under that list, it will basically say, it has like a check mark where it'll say yes, a column that'll say yes, audio only if it's allowed. And there's more no's than yeses. And so make sure you have a copy of that list to be able to check that out. Number 3 would be too many level 5s billed when there's not supporting documentation. So remember, a telehealth visit lacks a certain history. Unless you're really doing a history over the airwaves, and it definitely lacks a certain exam, then you're supposed to just be able to do what you can do. But then the medical decision-making is not also supporting the code based on the presenting problem, and it's typically low or moderate, or the actual record lacks the time that's needed to get to a level 5. And remember, we're still in the 95-97 guidelines for another 5.5 weeks. And so that means that you would have to have for a level 5 new patient visit at least 60 minutes documented, and it would have to say that 50% or more was spent counseling, or you would have to have at least 40 minutes documented for a level 5 established visit. And we're not seeing time in a lot of these services where it was a level 5, and then we try to go with the rest of the note if we don't have time and it's just not there. So that's a really big deal. No consent. So Medicare was back and forth on this. Many of the commercial plans were not. They said you have to have, first it was written consent, then it was verbal, and then verbal for a year. And Medicare's also rescinded that as well. So they had a 5-minute brain, I like to call it a brain fart, because basically they were just like, no, consent isn't necessary. And what they finally rolled that back to on one of their office hours calls is that consent is not necessary on every visit. So if you have a verbal consent, it really should be brought forward and dated, so we know how long it is good for. And it's good for up to a year from the initial time you got the consent to see the patient. So make sure that is part of the record. Number 5 is no evidence of the patient was informed of the compromised platform. If you're using if you're using FaceTime or Skype, because if it's not HIPAA protected, remember, under the 1135 waiver, you were supposed to let the patient know. Say we can use FaceTime or Skype or Google Hangouts, something that wasn't a public-facing platform, so it had to be something that the patient could have privacy, but you needed to let them know that it wasn't as private as, let's say, MyChart and Epic or Microsoft Teams and NextGen. So in the EMR situation, so you had to let them know, and it had to be in the record. And I would say I find that probably 80% where it's not in there. And I was very, very clear with my clients that you had to have that in there. Actually gave them a script of what should be in there. And then the provider providing the telehealth is not an approved provider. There is a list, just like there's a list with everything. So make sure that you are following that list. A lot of times we're seeing that providers who think they're on the list because they expanded that list so much was providing something under a telehealth guise, and they were not covered under telehealth, and we find out later on. So that's a problem. Number 7, dietitians, nutritionists billing a telehealth visit, either incident to the physician or direct, when the patient is not diabetic or does not have chronic kidney disease. And remember, they have a very limited scope, and all of a sudden Medicare starts getting a flood of dietitian and nutritionist claims, and the patient may be having bariatric surgery, but that's just an in-office part of a physician's information. That's not a separately billed charge above and beyond the E&M, if you want to include that. It's only a separate charge if it's diabetic counseling and the patient has that diagnosis, or they have a kidney transplant or chronic kidney disease. So remember, that is not something that you can all of a sudden open up the scope of what that coverage policy is just because we've switched to telehealth. Number 8, this kind of goes back to what we were talking about, number 6, the provider not being on the list. Well, a lot of practices have decided they're going to let their MAs and their RNs, their LVNs and LPNs now provide phone calls under the telehealth, which they are not approved to do that. It has to be an approved provider. So, a clinical social worker, a physiologist, a psychologist, or a provider, an OT or PT, a provider that's not a physician or not an advanced practice provider like an NP or PA. But if they're doing any kind of phone calls that are allowed under the telehealth, first of all, they have to be a physician on that list if they're a non-physician provider. And secondly, that phone call has to be approved. But when I see MAs calling up patients where you're not supposed to do that, then I'm definitely having a problem with, having to deny that claim. Now, number 9 is a big one, and this is soliciting patients under telehealth. So basically doing something that you're charging for something now that you never did prior to the public health emergency. Calling the patient and telling them that they have a normal test result and that making them an appointment and trying to charge that as a phone call. And that is a big no-no. Please don't do that. That is, talk about a red flag for an audit. Remember, don't charge for services that you didn't charge for prior to the public health emergency. If patients want to look up their test results, especially if they're normal, they should be available under the patient portal if you have that available in their system, or there should be part of your triage for calling patients as far as we'll let you know what your MRI said or what your lab results said. Then that's something that you're going to call them and let them know. If there's a problem and there needs to be a specific scheduled encounter because it was an abnormal test result or an abnormal study, and it has to be a formal encounter, an audio video visit, then make sure you schedule that and set it up. But for a normal test result, we're getting a lot of these phone calls, which are just not medically necessary. And that's where it's becoming such a nightmare for Medicare. And they're thinking, wow, we gave all this flexibility on some things to be charged, and talk about taking advantage. Number 10, and this is one that kind of made me a little sad because everyone should really know better, but unfortunately we have to put some, and Medicare has to put some handcuffs on this. So more than one phone call per day. So you should know just by reading the rule on phone calls, and know that those are rolling back once the PHE is over. It'll only be audio, video, and only in certain rural areas and back to the HRSA and the shortage areas. But CMS actually on October 1st in this fourth quarter had to add an MUE, which is a medically unlikely edit. So how often you can provide a service on a given date. Under the CCI edits, they had to add no more than one phone call per day. And they also have a reminder, no more than one per 7 days. So remember, there's a kind of an innate global on a phone call where you shouldn't have more than one every 7 days, and you shouldn't never have more than one per day. There's also an edit, and I guess this is 10A since I'm just doing a top 10 list. There's an edit for portal visits on the same, or digital e-visits on the same date as an E&M service. So before it just said not applicable, but some of the MAC carriers said that their system were getting all of these, office visits and telehealth visits, and then they were also getting a digital health visit or a portal visit, which is not allowed on the same date as an E&M service. Because remember, portal visits or digital visits that they just started paying for are considered now are part of, or they're cumulative. So if you have 3 or 4, if you have a patient getting 3 or 4 accesses to their patient portal and back and forth questions with your provider, it's cumulative over a 7-day period. And you're not supposed to charge that on the same date as an E&M. And again, that's that 7-day. So the CCI edits had to add a 0 indicator reflecting no modifier will help you when an E&M service was billed with any code in the 99421 to 99423 codes and 99441 to 99443 codes. So just remember that too much of a good thing is too much, and please don't abuse the system. We want telehealth to be expanded, and we want it to at least stay here in some kind of effect when after the PHE ends, which right now is through January 23rd with the extension. But if it's abused, they'll take it back, and we just don't want them to take the entire services back, because there is a place for it in the delivery of healthcare. So our coding question today is something that seems like it's everywhere on my email membership this week of what everybody's asking. So basically it's talking about, and it said, Terry, do you know about anything about the CPT code for reporting additional practice expenses during the COVID-19 public health emergency? It was released somewhere in September, and what does it include, and how do we use it, and what does it pay? So in September 8th is actually the specific date. The AMA, which is CPT, introduced a new code 99072, and here's the descriptor: additional supplies, materials, and clinical staff time over and above those usually included in an office visit or other non-facility service when performed during a public health emergency and defined by law due to the respiratory transmitted infectious disease. Okay, so in response to the significant additional practice expense related to activities required to provide safe medical services to patients during the PHE, over and above the usually included medical visit service, so this is also in a CPT assistant, basically the personal protective equipment, so it's a PPE code 99072, that was put out there. But here's the thing: Medicare has said that it does not have value as far as an extra service. This is included as part of your E&M service. Just because AMA puts it out there doesn't mean it's something that you can charge for. And Medicare didn't just say it wasn't covered. They said it was bundled into an E&M service. And remember, bundled means included. It means you're already getting paid for it. Now, if you have some private payers, here's what you have to document. And this is part of a CPT assistant. It says any time beyond the time for the primary service spent by clinical staff. So it has to show that it's above and beyond what you're usually doing. And it talks about in the screening for patient symptoms, before and after the visit, including instructing the patient on PPE protocols, applying and removing PPE and sanitizing the visiting room, and also, 3 surgical masks. I actually said 3, which I thought was interesting. Any supplies used in the sanitizing process, hand sanitizer, disinfecting wipes, sprays, cleansers that you didn't have before. But it is vague on the documentation requirements as long as you do include that information. But just remember that you have to know which third-party payers are going to pay. I know I'm having better luck with dental payers that are paying, I think, $10, and one said that they'll pay $50, but over a period of, or once per patient per lifetime. And so when you're dealing with the medical providers, I'm seeing here and there a provider might pay. There's a random Blue Cross that'll pay. When they say there's no RVU, but we'll pay $15. So please check with your payers before you start billing this out. The other option is you can charge your patients that are not Medicare, because again, Medicare says it's included in that daily encounter, but let your patients know that it's not something that's going to be reimbursed by the payer and that they'll be responsible for it. So, and they'll probably want you to bill it thinking, my insurance company, of course, will pay it. No, of course they won't. So this is just something that was created, I think, just to have it in there. And at some point, you may have the payer buy into it. But for right now, I'm finding 90% are not covering it extra. So please be aware of that before you start introducing it into your practice and have a physician meeting and make that a discussion as far as what you're going to do with that. Our coding question is brought to you today by Modern Healthcare Magazine, the only healthcare business news weekly, Chicago, Illinois, modernhealthcare.com. Okay, so my personal tidbit this week, the Steelers are 10-0, yay. I'm so happy about this. It's a great distraction from everything going on. And also I wanted to bring up, as you head into Thanksgiving this week, since we are all in the medical field, I do wish that everyone has a safe and happy holiday, but please use really good judgment when it comes to the spread of COVID and just trying to keep everybody safe. I actually had to cancel my daughter's flight to visit us in California since we're back up a mode in purple, and we have actually a new curfew here, which actually doesn't make sense to me. It's 10 p.m. to 5 a.m. Aren't we, most of us, asleep during that time? So I'm not really sure what that is, but because of the uptick in cases, they have limited and really been hammering us on not having get-togethers. But, it's also a free country, so you're going to do what you want to do, which I think you should, to be able to do what you want to do, but you want to use discretion, because I'm sad that I don't get to see my daughter. But regardless of how you celebrate, please use just really good judgment. Try not to, and I'm just going to put out a couple things that maybe you don't even think about. Try not to taste food off someone else's plate. Wash hands before and after eating. And if you have good weather, try and get the gathering to move outside, because we know ventilation really helps. And I know you're sick of hearing about the masks and all that kind of stuff, so I'm not going to talk about that because you know that. And we're probably sick of the phrase social distancing. And trust me, no more than anyone is sick of it. But for this PHE to end, we need to at least try to be socially responsible. So if you could just limit your exposure, it would go a long way, especially if you have older relatives. Just be very safe and careful out there. So everyone, make it a great day and a great week. Try not to eat too much turkey. It's homemade lasagna in my house on Thanksgiving, so we're looking forward to that. So I'll talk to you next week on the Codecast podcast. Have a great week.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.